It is my pleasure and honor today to have all this gathering from Arab world. I hope it will be very nice, exciting session because we have experts in the field of transplantation, pediatric transplantation, Professor Bassam and Professor Fatina Fadel. Both of them are interested, and this is their specialty. But if you allow me, before introducing the session, it was a very terrible pain for me and for all Arab colleagues in the nephrology community that we missed Dr. Shafiq Al-Ahmad. He was very unique in character, and I read in the Facebook and a lot of the social media that he was unique in his characters and humanity. And he was lost yesterday in the battle of COVID-19. So it is a big sorry. And we pray for Allah to forgive him and to accept his work, because he was a very nice person and was knowledgeable, expert, and left a lot of mercies. Dr. Shafiq Al-Ahmad attended with us many meetings, and I witnessed his experience and his expertise in the nephrology. Let's start the introduction of this session by welcoming our guest speaker, Professor Bassam Saeed. He's a senior because this is the date of birth, July 60, and he has a very nice and very professional CV. He is currently consultant of pediatric transplant nephrologist at a private clinic in Damascus since January 2019. He is honorary fellow of the Royal College of Physicians, Edinburgh. He is the founder and the president of the Farah Association for a child with kidney disease. And I'm going to highlight a few points about Farah at the end of the introduction. He's the immediate past president. He just finished his presidency to the MESOT by 2000, and this is the date of immediate past president. The member of the Scientific Council of Pediatric Nephrology, subspecialty of the Arab Board of Health Specialization, Council of Arab Health Ministers from November 2016 to date. Is a member of the Declaration of Istanbul Custodian Group, and I witness his ethical writing through the Facebook and a lot of media. The member of ICN Middle East Regional Board, member of the Committee of the Advanced International Training course in Transplant Procurement Management from Spain, founding member of the World Academy of Medical, Biomedical, and Ethical Sciences, member of the Declaration of Istanbul, country representative of Syria in Transplantation Society, and representative of Syria in the Mediterranean Transplant Network, and is the regional representative of Middle East, Africa region in the KDIGO, and this is very prestigious because all of us follow KDIGO guidelines. He has many appointments and occupations in the past and the present, so he is well known. As you see, these are previous occupations: consultant at Kuwait Hospital, president of the Middle East Society from 2016 to 2018, head of pediatric department and kidney hospital at Damascus, director of pediatric nephrology fellowship, a lot of appointment. He also is an editorial board member and reviewer in many regional and international journals. He has more than 47 publications in peer-reviewed journals, as well as number of reviews, editorials, and textbook chapters. So this is very nice to have both academic and research activities. And these are the most recent publications, a small review about how did the war affect organ transplantation in Syria, very nice in the January this year, supplement of the experimental and clinical transplantation, and the supplement of July in the same journal, deceased organ donation in Syria, challenge and solutions. So a lot of publications. Regarding the Farah Association for Child with Kidney Disease in Syria, it's a very nice and very prestigious. It is non-profit voluntary charity organization, duly registered as society affiliated to the Ministry of Social Affairs in Syria, with the effect since more than 7 years. The main mission is to build hope and provide help and service the needs of kids suffering from CKD and their families, as well as to promote support for kidney donation and transplantation for children in Syria. Very nice and very important job for Farah Association. Also from just some photos, and I acknowledge the help of Professor Saeed Khamis for sending me some photos, and this just reflects how Professor Bassam Saeed is interested in the community. Because as we do renal transplantation, doing a village and plant, it is transplant. It is carrying a hope for the community, and he is a unique human being and a fantastic family. He is a very prestigious ambassador to the Arab world in the many international conferences, as you see in these photos. In Japan, a lot of prestigious photos in different areas in the world, and this in Egypt, Hatshepsut, Luxor. Always we love to meet Professor Bassam Saeed because we are touched by his civilization and his mode of dealing. And this is the photo during the Jordan Society of Nephrology meeting early this year in February. And this photo is very important for me because it has both Professor Bassam Saeed and Professor Fatina Fadel, and she is the moderator of this session, and she is a well-known figure in Egypt in pediatric nephrology. All of us admire her, and this is the society, the key figures in the Society of Pediatric in general, and pediatric nephrology, because this is Professor Ramzi Al-Parodi, is well-known. And myself, I admire the Professor Amr Sarhan because he is very, his attitude is very humane, and he was the past dean of Mansoura Faculty of Medicine. I know him well, and always up to this moment, I learn from his attitude. Professor Fatina has a lot of efforts. This is in Aswan. When we have the workshop for intervention nephrology and other aspects of nephrology, a lot of activities, and this is in Aswan too. I want to congratulate Professor Fatina for publications. She has many publications in the field of transplantation, and this year in the same journal, Pediatric Transplantation, in the same date, 7th of April, she has 2 publications. This is one of them, 10-year single center experience of pediatric kidney transplantation in Egypt. So congratulations for this work. And the second is, and it's very interesting, the transplanting children with lower urinary tract abnormalities. So in the same journal, accepted in the same date, and they are still in press. Because this article is very interesting for me because when we have children or adults with problems in the urinary bladder, we face a lot of problems of urinary tract infection and a lot of admission to the hospital. And I think this will be discussed, and one of the challenges of transplantation in general and in pediatric age in particular. We have our experience in Etiology and Nephrology Center Mansoura because the transplantation service started even before founding the center by Professor Ghunaim at Mansoura University Hospital. So the total transplant at our center is 3,128, and transplant was cut down in the 11th of March, but I'm hoping by the next week we'll go back to our activities of transplantation. Among this 3,100, we have almost 500 pediatric patients. Usually they are in the adolescent age because the limited age for us is 5 years and 15 kilograms to proceed for kidney transplantation. So we have few patients below the age of 5. And if you see, this is one of our kids who was transplanted, and you see immediately after recovering the pain of the wound, he is playing the games on the, and this is fantastic because we have our data, we have more than 25 publications in pediatric transplantation, and this one of them 28-year evaluation, and this was one of our old publications. And we learned that the children are facing a lot of problems. Rejection, quality of life, CKD, MBD, a lot of problems. But what we learned is transplantation is the hope. Because if we compare transplantation to dialysis, we'll find there is no comparison. Transplantation is the best offer, but it is not void of complications. I'm sure today it will be very wealthy session, and because we have a unique guest speaker, Professor Bassam Saeed, and an expert professor of transplantation, Professor Fatina Fadel, and we have Professor Riyad Saeed, Professor Faissal Shaheen, and a lot of experts will join us and will share in the discussion. I'm going to stop my slides and start sharing the slides of Professor Bassam Saeed, but I like to hear from Professor Fatina, few words about Professor Bassam.
First of all, I would like to welcome Professor Bassam. Welcome, Professor Bassam. And we are looking forward for hearing your talk about the first session in pediatric kidney transplantation talks. Dr. Bassam, I met him many years ago, I think more than maybe when you visited our unit, Professor Bassam, I think it was more than 10 years ago. And at that time, it's about 12 or 13 years ago, because at that time we were not yet started the renal transplantation in our unit. We were transplanting our children in Qasr Al-Aini Hospital. And we talked together about his experience in transplantation, and then we started in our unit, and since that time we are sharing knowledge, sharing meeting together in several conferences and meetings. So I'm looking forward with all our colleagues from every part of the Arab world to hear from Professor Bassam and hear about his long experience in pediatric renal transplantation. Thank you, Professor Hussein, for inviting Professor Bassam for this very important session. And I would like to also thank Professor Hussein for his very big effort he's doing for gathering all these scientists, the experience between all the Arab world doctors from everywhere. Thank you, Professor Hussein, and thank you, Professor Bassam, and looking forward for your talk.
Thank you very much, Professor Fatina, for your nice words. And now, please unmute yourself, Professor Bassam.
Okay. Thank you very much. First of all, thank you very much, Professor Hussein, for your great introduction, which I do not deserve all this. It's amazing how you present people, and I think this reflects you before anything else. Thank you very much. would like to extend my thanks also to Professor Fatina for the also good remarks. And I was privileged, in fact, when I visited your department, I was amazed, and the huge volume of work, the quality of work, the everything, the research coming out from this department on a regular basis. It was something that pushed me also, and may push everyone that visits your department. I do appreciate all your efforts. You are a nice team. What Professor Hussein is doing, in fact, this is a source of honor and a pleasure for anyone from the Arab world. This is especially in this difficult time where we can't meet. I think now this is one of the best moment and occasion for any one of us to share knowledge and experience. Thanks again, Professor Hussein.
Thank you very much. Thank you. You are welcome, Professor Bassam. Thank you.
So our topic today is about pediatric kidney transplantation. An overview, let me say, about pediatric kidney transplantation. This is the issues that I am going to discuss with you. First of all, burden of CKD Middle East perspective, kidney transplantation in infant, graft survival, immunosuppression strategies, patient survival, novel long-term risk, especially cardiovascular and malignancies, growth and bone disease, infections, recurrent disease, and global access to transplantation. So let's start by the burden of CKD Middle East perspective. This is our mission. Our mission, in fact, especially when it goes for pediatric nephrologists, it goes far beyond our traditional work for taking care of patients with chronic kidney disease. When we deal with a kid, of course, we have to handle so many difficulties and so many different kind of suffering, social, psychological, educational, familial, so many challenges. So our mission is not only just to do transplant or giving medications or doing investigations. So our mission is, first of all, a human mission, taking care of those kids who live the pain and the suffering for the rest of their life. Next, please. I would like to start by referring to what it was said before, maybe 30 years ago, by Dr. Sesh from Chile, Santiago, that pediatric nephrologists in developing countries make a stronger plea for the elimination of discriminatory practices against children. I'm sorry to say this, but because this is part of the issue. The pediatric nephrologists in developing world feel that sometimes they are struggling just to have the same right for the same patient in the same place, just with difference of size and age. I can tell you one thing happened, unfortunately, 15 years ago in some congress, that one eminent doctor told me when I was talking about kidney transplantation. He said that if we pay money for vaccines and antibiotics for kids, that would be better. I told him, I hope that one day you will not think otherwise when one of your kids will suffer from renal failure. This is one of the problems that we are facing when we practice pediatric nephrologists. So pediatric nephrologists in developing countries claim the same rights for subjects who were living in the same country, but with the unique difference of age and size. Next, please. I have taken permission from all the families and those kids before putting their faces and names. First of all, Sheashaa, she was on dialysis for maybe 2 years, then transplanted. And now, maybe 7 years after transplantation, she is doing extremely fine. Now she's going through university, extremely good functioning graft. But unfortunately, the story is not always very successful like Sheashaa. If we go down to Yazan, yes, this one on the left side, Yazan, in fact, he has oxalosis. So oxalosis, as you know, is much more complicated than simple renal failure because those patients, they require both liver and kidney transplant. So this child has undergone, first of all, partial liver transplant from his mother, the lady we are seeing here. And maybe 3 months later, the patient also undergo kidney transplant. So the kidney transplant in pediatric patients is not always straightforward, just we transplant. We have to look at the etiology and then we do our job accordingly. So this patient, now he developed some major complications after liver transplantation, then things improved and now he is doing very fine. He had 2 transplants, liver and kidney transplant. Now, right hand, the upper one, Hind, she was transplanted maybe 10 years ago, the first transplant. Slowly, she developed chronic kidney disease, chronic allograft nephropathy, until she lost her kidney function. And again, she was transplanted last year. Now she is doing fine with her second transplant. So now in pediatric nephrology, we start talking about retransplantation, because usually before, the patient used to have his first transplant during childhood and the second transplant during his adulthood. Now we start seeing retransplantation both during childhood. So this is unfortunate, but fortunately, the patient was transplanted again and now she is doing fine. The last one, Joseph. This Joseph has developed antibody. He was transplanted maybe 7 years ago. And after that, he developed acute antibody-mediated rejection and did not respond to any treatment. And he lost his graft maybe 6 months after transplantation, and he returned to dialysis. And he has very high PRA and very high double DSA donor-specific antibodies. It's very difficult now to find out some appropriate or suitable donor for him. So these 4 stories explain a little bit what are the difficulties that we are facing. There is no always good evolution every time. Unfortunately, sometimes the evolution is not that good, and the doctor has to be ready to make the necessary and manage all these cases appropriately. Next, please. Renal failure during childhood is very different from renal failure in adulthood. Kids with renal failure has lots of complications and abnormalities that we do not find mostly in adult patients with CKD, especially with regard to abnormalities of skeletal development and growth retardation, because most of them, they are short stature, sometimes with some bone problems. And also, especially when the kidney failure starts early on in childhood, they do have abnormal neurocognitive development and pubertal delay and disordered psychosocial maturation. So that's the reason why when I say those patients require a special management and special follow-up to take into consideration all these associated abnormalities. Next, please. That is the reason why we try sometime to implant happiness in those kids, because they feel frustrated, they feel sad all the time, they feel a bit different from other people. Why they do have renal failure, other children they do not have. They do have disturbed social life, educational life. Everything is disturbed in their life. So for us, it's our duty also to try to help them, try to implant happiness and smile on their faces by doing parties. This is, for example, a Christmas party in pediatric dialysis unit. Next, please. What about the burden of pediatric CKD? In developed country, they do not have problem because they do have registry. So in North America, for example, the North American Pediatric Renal Transplant Cooperative Study, the prevalence is 72 per million population, while in Europe is 33.6 per million population. Now, next, please. When we look at Middle East countries, unfortunately, we do not have a registry, as you know. There is a scarce epidemiological data on CKD in children. When we look in the internet, looking for studies performed to know about the incidence and prevalence of CKD in pediatric patients in the Middle East, I found out one of these, like this one from Isfahan in Iran. It talks about the prevalence of CKD stage 3 to 5 among students of Isfahan. It was 118 per million age-related population. It exceeds what we saw in Europe and developed country. But we have here to mention always that when we refer this number of prevalence, we mean million age-related population. I mean 1 million pediatric population. Next, please. Let us look at the incidence and the prevalence of ESRD around the world. On the left hand, we see that the incidence, how many new cases per million population every year in different parts of the world where they do have registry. We see it differs actually, this incidence, roughly speaking, from 5 to 10 cases, new cases every year per million population, per pediatric million population. On the right hand, we see the prevalence. The prevalence you may see in Italy is very high because in Italy they take this statistics till the age of 24. The rest of countries up till the age of 19 years. You see the prevalence somehow is something around 50. So in 2 words, the incidence is 5 to 10 globally, 5 to 10 cases per million population per year, and the prevalence is 50. If we take a country like Egypt, for instance, 90 million population, and the incidence is, let me say, 10 cases per million population per year, which means that every year we do have 900 cases of end-stage kidney disease, 900 cases. And the incidence, we have to multiply 90 by 50, it will come maybe 4,000 patients already now, they do have end-stage kidney disease. Next, please. The epidemiologic information from Arab countries, as you know, is very scant. It is primarily based on patients referred to tertiary medical center. It is not based on national registry, based on the Ministry of Health or whatever. This makes our job more difficult to understand what's going on and what are the health policies that we should do in order to solve all these issues. Next, please. Look here. I have taken this study from Professor Adib Rizvi from Pakistan, who published a very interesting study about the etiology of ESRD in children. And he did compare his results with another Middle Eastern country, which is Turkey, and North America and Europe. So we have 4 columns here, as you see. First of all, in Pakistan, I will not go into details and looking at how much glomerular versus tubular interstitial versus hereditary. That is not the aim of this study, of this slide I put here. What I wanted to do here is just to show you, next please, is to show you the unknown cause. The unknown cause in Middle East country, like in Pakistan, up to 50%, in Turkey, up to 38%, so huge percent, unknown. So almost half of the patient, when they reach end-stage kidney disease, we don't know why. And this is a problem, because when we don't know why, as you know, some diseases may recur after transplantation. So if we don't know the why, then when we do transplant, there might be some problem related to this. But if we look at the North American, the 3rd column, North American Pediatric Renal Transplant Cooperative Studies, the percent is only 6.2, and the last one in Europe is 7.4. This is very acceptable. So this is one of the major obstacles also toward managing patients going to be for transplantation without knowing what was the cause of their. So back to my country, I did this study maybe 11 years ago to look at the causes of chronic kidney disease in Syrian children. It was single center, of course. So it is not a registry nationwide. But in my single center study, I find out that obstructive nephropathy was the single most common cause of chronic kidney disease. I did find some similar results in Jordan, but otherwise I couldn't find that obstructive nephropathy could be the single most common cause of chronic kidney disease. This is one of the particularities of CKD in children in our area. By the way, next please. By the way, this I won an award for this study because it was selected as one of the best abstract presented in the World Congress of Nephrology in Milan 2009. Next, please. Now, what are the advantages of kidney transplantation over dialysis? These advantages usually we tell the parents of any patient undergoing dialysis in order to convince the family and the patient to go for transplant, because better quality of life, no question, better school performance, cost effective, not only for the government, but for the patient, provide near normal growth, because the growth is a big issue for the children, especially adolescents, and reduce family problems. You know, because sometimes going to dialysis 2-3 times a week, most of the time we see that the family life is disturbed completely, that sometimes the father lost his job, etc., etc. Next, please. What are the factors that affect the fate of kidney transplant? There are many, not only those on this slide, but importantly, the donor age. The donor age, we prefer always to have young for young policy. For example, if we have a child, better if we have his brother or his sister, older sister or older brother, than his mother or father. And also cold ischemia time, living better than cadaveric, HLA mismatching, and also experience of transplant center. Many things we can change, but other things sometimes cannot be changed, you know. Depends on the possibilities and the expertise and the potential donor. Next, please. Now, going back to transplantation. Are we transplanting enough worldwide? It seems not at all. It seems, according to WHO, we are transplanting only 10% of the global need. Not only this 10% is the globally. But if we look at certain region, because here, this slide is from WHO, from this slide, we see the 6 regions, according to WHO, we see 4 regions where 80% of the global population live. We do here in these 4 regions, including our region, which is Eastern Mediterranean region, which is based in Cairo, by the way. So 80% of global population performing only 20% of total transplant. So organ transplant rate differs significantly between countries. So in the Middle East, we are transplanting a bit better than other Middle East, other region, say Africa or Asia, but far less than what they do in Europe and North America. Next, please. Now, if I wanted to understand about pediatric renal transplantation from Middle East country, as I said, we don't have registry. So I have to go through single center experience, published single center experience. This is the studies that I could collect from different countries, as you see, Algeria, Egypt, Iran, Jordan, Kuwait, Oman, Pakistan, Saudi Arabia, Sudan, Syria, Turkey. Each of these studies with the number of transplanted patients and the follow-up period and year of publication and in which journal. And that is the only way, and in fact, to have an idea about our results: graft survival, acute rejection rate, complications, infection, cancer, etc., etc. Next, please. And this is also another study I did and published in Saudi Journal of Kidney Transplantation like 7 years ago about pediatric versus adult kidney transplant activity in Arab country. On the left side, we see the total kidney transplant. As you see here, in one single year, in the whole Arab countries, a total of 3,309 kidney transplants were performed in 1 year, which makes the rate of kidney transplant per million population 9.5 which is acceptable, but still of course, far less than what we see in Europe, for example. And out of these 3,309 kidney transplant, only 212 cases from deceased donor, which makes the deceased donor in Arab country representing only 6.4% of the total transplant. Next, please. Yes, here we see the total pediatric kidney transplant out of this 3,000. So 298, almost 300 kidney transplant out of 3,309 went for pediatric recipient. Next, please. Which makes the pediatric kidney transplant rate 2.44 kidney transplant per pediatric million population. We will see later on whether this is acceptable or not. It's not acceptable, of course. And this pediatric share represent 9%. So pediatric transplantation represent 9% of the total transplantation in Arab countries. Out of this 298 pediatric kidney transplantation, only 29 came from deceased donor, which means that deceased pediatric kidney transplantation is responsible only for maybe 9.8 or 10%. Next, please. Now, looking at this same point, living versus deceased donor pediatric renal transplantation in Middle East. For this slide, it is for the Middle East, not for the Arab country. In red color, this is deceased donor pediatric kidney transplantation. As you see here, only few countries they do have regular deceased kidney transplant program. For example, Saudi Arabia, Kuwait, Turkey, Iran. Probably it does exist in Lebanon a little bit, recently in Emirates and in Qatar, in Tunis also, but pediatric kidney transplantation from deceased donor only in those 4 countries. In Saudi Arabia, 50%. In 50% of pediatric kidney transplantation were from deceased donor, and the other 50% from living. If we look at Kuwait, there's no huge number of transplantation, but 1/3 from deceased. In Turkey, maybe 13%, and in Iran, 5%. Next, please. If we compare our results with the United States, here from the North American Pediatric Renal Transplant Cooperative Study, we see that maybe up to 60% of pediatric transplantation are from deceased donor, 60%, and 40% from living donor. Next, please. Now, again here, total versus pediatric kidney transplant in the Middle East. As you see here, Iran is doing the most as absolute number compared to other Middle East countries. As you see here, that the total number of kidney transplantation in 1 year in the whole Middle East is 7,672. Out of this, 568 kidney transplant went for pediatric recipient. So the pediatric kidney transplantation does exist, maybe something around 7 to 10% differ between countries, but is it enough or no? We don't have clear answer for this because we don't have the registry, we don't have the accurate data about the incidence and prevalence of end-stage kidney disease in pediatric population, because all what we said is based on tertiary care center study. Next, please. So again, here we see that the population of the Middle East, as you see here, about 650 million. The total kidney transplant, the total pediatric and adult, was in 1 year 7,672 kidney transplant, which makes the kidney transplant rate per million population is 11.8. When we look at pediatric population, according to WHO, pediatric population in Middle East countries are 35% of the total population. So we do have 227 million pediatric population in the Middle East. So when we transplant 568 pediatric kidney transplantation in Middle East, this means that the pediatric share is 7.4%. And the pediatric kidney transplant rate per pediatric million population was 2.5. Now we will look at international experience. Next, please. This is from international. You see here in Spain, for example, they do transplant up to 15 kidney transplant per million population per year. In the Middle East, 2.5, the average. But in the international level, in those countries where they do have registry, you see here that it varies, of course, between countries. But in Catalonia, maybe because this is one of the, this is the most active center, the most active region worldwide in transplantation, especially from deceased donor. But globally, you see here that the average, maybe something around 6 to 9 pediatric kidney transplantation per million population per year. Next, please. This is a Middle East country. Next, please. You see the average in Middle East country, as I said before, 2.5. But if we look at each and every country, we see in Jordan, for example, 8.8. But here again, in Jordan, they do have very active, but probably at that time, they used to have some patients coming from Yemen, from Libya. So I guess that not all these 8.8 cases per million population are for Jordanian recipient. I don't know exactly those who are Jordanian. Anyway, they did 8.8 pediatric kidney transplant per million population per year, which is good. In Turkey, less, but the average, as I said, in Arab country is 2.5. Next, please. In Middle East country, sorry. Now, what about the pediatric share? It was interesting to know that in Algeria, almost 1/4 of transplantation went for pediatric recipient. But regarding other country, as you can see here, the average, next please, the average was 7.4%. So the pediatric share in the Middle East is 7.4% of the total transplantation is going to pediatric recipient. Next, please. If we compare this with Europe, this slide from Pierre Cochat from France was published maybe 12 years ago. The average in European children of total transplant is 4.5, but we have to here wait a little bit before jumping to conclusion, because the pediatric population in Europe is maybe half of that in the Middle East. As I said before, pediatric population in the Middle East is 35% of the population compared to maybe half of this. It seems that maybe 16 to 17% of the population in Europe are kids. Next, please. Moving to kidney transplantation in infant. Next, please. As you see here, when you put an adult kidney in an infant, you may say it's impossible to accommodate this big kidney. In fact, infant may receive adult kidney. This is a message. Next, please. But before we go for transplanting infant, we have, first of all, to do early referral and good evaluation of the child at transplant center, not at dialysis center. And the patient must be screened for infection and ensure that he is up to date or she is up to date immunization, including influenza. And we have to correct all possible or potential urological abnormalities pre-transplant. Some patients, they may need bladder augmentation, and they do have, for example, neurogenic bladder, etc., etc. And this is not a far possibility. And lastly, but not the least, is to optimize the dialysis treatment. Many patients, they are under dialyzed with cardiomyopathy and anemia, especially in small kids. So we have to optimize dialysis treatment and encourage compliance. Next, please. Now, as I said, infant may receive adult kidney, but of course, we have always to consider the size disparity. This is the business of the surgeon. The surgeon has to do the anastomosis, both vascular and ureteric, in a special way. The vascular should be with central vessels, with aorta and inferior vena cava. And the baby is in huge need for intra and post-operative ICU care. This is the key message for a successful transplantation for an infant. The intraoperative and post-operative ICU care. which may extend up to 3 days after transplantation. And sometimes if we transplant in abnormal lower urinary tract, then this has to be approached properly before transplantation, not during the transplantation. And as I said, when we transplant kids, when they are too small, then one has to consider that one day those kids may be retransplanted during their childhood. Next, please. So infant may receive adult kidney, but there are several things that has to be accomplished. We know already that those kids will have, after successful transplantation, will have excellent short and long-term outcome, in contrary to what many people may consider. They may say this is difficult and outcome. This is difficult, yes, require experience, yes, require so many things, yes, but the short and long-term outcome is excellent. And it's better than all other age categories. Surgical management, we used to use aggressive intravascular volume support and to do central vascular anastomosis. Both of these 2 points are very critical to maximize renal perfusion in order to achieve good early renal function. Next, please. As you see here, the anastomosis, the renal artery with the aorta directly, and the renal vein with the inferior vena cava, and the ureter as usual. Next, please. This is very challenging. If you look at this adult kidney and the small belly of an infant, one would say, oh my God, how can I put this big kidney into this small belly? We have to remember always that this kidney after transplantation will shrink to size, so no worry. But with time, it will grow again with the child growth. Next, please. The most important point is to pay attention to the hemodynamic, especially when re-establishing the circulation to the grafted kidney. We have to ensure an enough blood flow to the kidney with good blood pressure and good blood volume. Otherwise, patient may develop hypotension. Next, please. So, vigorous volume expansion prior to establishing circulation is a key message. Vigorous volume expansion. And replace all urine output for up to 72 hours, not only up to 24 hours. So cc for the initial 2 to 3 days. And we have to maintain CVP 8 to 12, not below 8. And to maintain blood pressure high normal or from 90th to 95th centile. You know, in pediatric, we don't give figures, we give centile. And we have to consider always the third space. Third space, because in infant, when we transplant, we do not transplant retroperitoneally, we transplant intraperitoneal. So intraperitoneally, this require, of course, bowel manipulation. And this bowel manipulation by the surgeon will result in bowel wall edema. And this bowel wall edema will create third space and the fluid loss. And this fluid loss are extravascular. So when we replete the intravascular volume, we have to take into consideration this third space. Next, please. And albumin is often necessary to maintain adequate blood pressure and CVP. Next, please. Our objective is to avoid hypovolemia in those infants, because hypovolemia will lead to hypotension, and hypotension will lead to renal hypoperfusion, and then acute tubular necrosis. This is of course, catastrophe. And acute tubular necrosis will lead to graft thrombosis and graft infarction. So hypovolemia is a starting point that we do not enter in it, because otherwise the patient may lose his kidney function. Next, please. As I said before, the outcome of those kids who were transplanted very early on in their life, before the age of 1 year, as you can see here from the North American Pediatric Renal Transplant Cooperative Study, we see here that in blue color, the graft outcome 60 months, so 5 years after transplantation, in blue, exceeding 90%. So the best graft survival in pediatric patient was achieved in those who were transplanted below the age of 5 years. If we look on the opposite side, those who were transplanted in orange between the age of 11 to 17 years, I mean adolescent age group is the worst group out, including not only among pediatric, but among adult, for several reasons, especially due this related to non-adherence. Next, please. It's very fantastic to look at this small kid when he was transplanted from a kidney from his dad and how he became when he became maybe at older age. Very successful and very beautiful to see this. Next, please. Let's see first the graft rejection rate. Of course, next, please. Next, please. Okay. If you look here from living donor on the left hand, you see here that acute rejection rate in the late 80, it was 54%. And in the late 2000, it was 8.7%. We have achieved a great success in reducing acute rejection rate. So one would say now acute rejection rate is really not a problem nowadays. It's not a problem. Of course, we cannot ignore that some patients, they still can develop acute rejection, and sometimes it's not always easy to treat, but compared to before, it's not a problem at all nowadays. And even from deceased donor, also the rate has decreased from 68% in the late 80s to only 17% nowadays. Next, please. I choose this study from Pakistan because Professor Rizvi here comparing 3 eras of immunosuppression. As you see here in the left column, in the late 80s, early 90s, the acute rejection rate at that time, it was 48%, almost 50%. But at that time, we used to use cyclosporine, azathioprine, and steroid, and there was no induction at that time. With time, of course, after the introduction of tacrolimus and MMF, the acute rejection rate has decreased to 35% in that center. The center is SIUT, Sindh Institute of Urology and Transplantation in Karachi. And the third era, which is the most recent one, the acute rejection rate has dropped to 17%. Of course, here we start using induction therapy, ATG and basiliximab. Next, please. Next, please. So you see here the graft survival is also improved a lot, but probably not to the same extent of acute rejection. The acute rejection, the acute rejection rate has decreased significantly. Here, survival has decreased in the North America from 81 to 90%, and also from deceased donor. Next, please. It also increased from 63 to 81%, which is good, but still it is not excellent. So I think we still have many things to do in terms of improving graft survival. So we were much successful in reducing reducing acute rejection than in improving graft survival. Next, please. Let's look at some Middle Eastern country. I have chosen these 3 countries, Iran, Pakistan, and Kuwait. And I looked at 1- and 5-year graft survival of pediatric kidney transplant. In Iran, for example, 1-year graft survival was 88%. In Pakistan, 92%. In Kuwait, 90%. That's good. 1-year graft survival in those 3 centers, something around 90%. I think it's good. When we look at 5-year graft survival, in Iran, it was not good, maybe, but nowadays it's better. 67%, but if you look at Pakistan, is 89, and Kuwait, 87%. So our result is not different, not much different from the West results. This is what I want and I meant by this slide. So again here, the graft survival in pediatric patients by age. Again, the same slide I have shown before. that those who were transplanted before the age of 5 years have the best graft survival exceeding 90%, and those who were transplanted in adolescent age group, they have the worst graft survival because it was something below 75%. Next, please. Here is the patient survival by transplant era. The patient survival is, of course, now is better with new immunosuppression era. If you look at the North American experience, this belongs to 2008. We see that patients who were transplanted from living donor in the late 80s and early 90s, in the black line, it was a little bit worse than what we see nowadays from in the dashed red color. So it is not much different, but now it is a little bit better in terms of patient survival. So patient survival in general in pediatric population, the patient survival is good, exceeding maybe something around 95%. So the mortality for pediatric patients undergoing transplantation is maybe 1% per year. So it is not that high. Compared to those, and I will talk about this later on, compared to those who were kept on dialysis. Next, please. And this is the evolution of GFR by recipient age. Those who were transplanted early on, before the age of 1 year, they do have the best GFR, even when GFR decrease with age, they remain, those who were transplanted early on, they remain having the best GFR compared to other age group, compared to those who were transplanted at later age. Next, please. Adolescents, as I said before, they are problematic age group because, as you see here, we have increased risk of graft failure when we transplant adolescents. Adolescents, as you see here, this dashed line, you see that the increased risk of graft failure is more among adolescents. So we have always to pay attention when we deal with an adolescent. Some pediatricians, they may consider that transplanting a small kid carries more risk. Not at all. The risk is there when we transplant an adolescent. Adolescent 15, 14 years, 16 years. Here we have to be very cautious, especially with regard to their compliance to treatment. Next, please. As you see here, the causes of allograft failure in pediatric patients, in green color, non-compliance. So non-compliance is the 6th most common cause of graft failure. You can see here chronic rejection, acute rejection, unknown causes, primary non-function, graft thrombosis, recurrent disease, and non-compliance. And on the right hand, you see that the non-compliance, especially high, the rate of non-compliance, especially in those aged from 13 to 17 years of age. Next, please. Now, this is very important slide because it tells us that it's not good for pediatric population to keep them on dialysis for a long time, because here we can see very clearly the adverse impact of extended dialysis time on graft survival. If we look at those who were transplanted preemptively, they have the best outcome. The graft survival for those who were transplanted preemptively, probably 80% here. And for those who were transplanted after being on dialysis for a period less than 6 months, it was a little less good than those who were transplanted preemptively. And you see here, the more the patient was kept on dialysis, the worse will be the result in terms of graft outcome. So the key message from here is that trying always to avoid extended dialysis time before transplantation. And if possible, of course, to go for preemptive transplantation. So now, the outcome of pediatric kidney transplantation, to summarize what I said, short-term outcomes of pediatric kidney transplant have improved and are excellent. The short-term and maybe medium-term. Young children are low risk and have the best outcome. Adolescents are a high risk age group, but long-term outcomes have not improved and are particularly important for children because their mortality rate are low. This is very important to understand this point, because those kids, in fact, their whole entire life is still in front of them. So they will not die, but they will suffer from the complications. That's why the long-term outcome matters much more, matters much more compared to adult. When we transplant a child who is 10 years old, it's not like when we transplant someone who is 70 years old, because this one, his life is still in front of him. So we have to care much more about the long-term outcome in order to let him avoid living with these comorbidities and complications, in order to have better quality of life. GFR, whatever we do, it will deteriorate constantly. Next, please. Now, what about immunosuppressive strategies? Next, please. As everybody knows that almost cyclosporine is not being used. It is replaced almost completely by tacrolimus, except in few countries where they still have their good result with cyclosporine. Same thing for MMF and azathioprine. So most of the centers worldwide now, they are giving tacrolimus and MMF. So cyclosporine is maybe for some other indications, and azathioprine very exceptionally used, probably only for those who were transplanted long time before, and they are kept because they are having stable kidney function. Next, please. Now, the tacrolimus is better than cyclosporine. So many studies has confirmed this. Not only the probability of graft survival is better with tacrolimus, but also the GFR is better. Not only the graft survival, but also the GFR, the graft function is better with cyclosporine, with tacrolimus compared to cyclosporine. Next, please. Now, the tacrolimus is better than cyclosporine, not because the acute rejection rate is less with tacrolimus. And this is proven by this study published in 2003, long time ago. It shows us that GFR was better in those who were receiving tacrolimus compared to cyclosporine, although the acute rejection rate did not differ significantly between these two groups. So it's not a question of better, less acute rejection or what, but the tacrolimus by itself, it protects the GFR much more than the cyclosporine. Next, please. What about the sirolimus or rapamune? Sirolimus, in fact, maybe 15 years ago, when we started to use sirolimus, at that time, many people was very enthusiastic to use it, but with time, it has decreased a lot, especially in pediatric population. Prednisolone, there are many centers in the West, especially in North America now, they start using minimization protocol. We will talk about this later on. That's why here, not 100% of pediatric population now are getting steroid as part of their immunosuppressive protocol. Next, please. What is wrong about current immunosuppressive medication? These are the medications that we use: cyclosporine, tacrolimus, steroid, azathioprine, sirolimus, everolimus, and MMF. Nephrotoxicity, as we know, cyclosporine and tacrolimus, otherwise nothing else can do toxicity. Probably cyclosporine is more toxic than tacrolimus. Hypertension, also calcineurin inhibitor and steroid. Hyperlipidemia, cyclosporine, but not tacrolimus, also steroid and sirolimus. Diabetes, calcineurin inhibitor, and here maybe tacrolimus is more than cyclosporine. Steroid also. Myelosuppression, here it is not related to steroid or calcineurin inhibitor, but antimetabolite like azathioprine, MMF, and mTOR. Hirsutism, steroid and cyclosporin, but not tacrolimus. Gum hyperplasia, only cyclosporin. Bone disease, steroid and calcineurin inhibitor. And growth inhibition, steroid, of course. Next, please. Regarding the use of induction therapy in the US, this is from the North American Pediatric Transplant Study. 50% of pediatric patients, they do not use any induction therapy. The other 50%, they may use 25%, they use basiliximab or daclizumab or some other induction therapy like ATG, but 50% they are not using. Next, please. What about patient survival? Patient survival differ significantly between those who went for transplantation and those who were kept on dialysis, whether it is hemodialysis or peritoneal dialysis. For transplant patient, the mortality, as you can see here, the patient survival is 95% after 5 years. Compared to those who were kept on dialysis, it is something around 80%. It differs a little bit between hemo and peritoneal dialysis, but there is a big difference, maybe something around 15% in terms of mortality rate between transplant patients and dialysis treatment. Next, please. This is the mortality rate stratified by renal replacement therapy method. As I said before, kidney transplantation, the mortality rate is 1.1 per 100 patients per year. So every year, one patient out of 100 pediatric patients with transplant will die. But the percent is much higher among those who are kept on hemodialysis, because instead of 1.1, it reached 4.8%, and in peritoneal dialysis, it's even higher, 5.8%. Next, please. What about the cause of death? Here we have to compare between dialysis and transplantation, and everybody can understand why infections and malignancy are higher as a cause of death among transplanted patients compared to those who were on dialysis. While regarding the cardiac mortality rate, it is not much different between transplanted patient and dialysis patient. Next, please. As you see here, the infection is a major killer. You see here viral infection, bacterial infection, and non-specified infection. If we combine all these three together, it will make something around 30% of cause of death, while the cancer is 10% and cardiopulmonary is 15%. Next, please. What about the cardiovascular morbidity? In the first year post-transplantation, 80% of pediatric patients, grafted patients, will develop hypertension. But after the first year, maybe half of them will remain hypertensive. Otherwise, the rest will become normotensive. And those who remain hypertensive, they will continue to be hypertensive for the rest of their life, as long as the graft is there. So hypertension is a big issue. And this is related essentially to the medication being used rather than the cause of their kidney function. Next, please. This is a very interesting study from Egypt, actually. It talks about the predictors of long-term graft survival. It was published maybe a long time ago in 2006 by Mansoura, by Dr. Amr al-Husseini, Muhammad Foda, and Muhammad Adil Bakr, our friend, and Dr. Ahmed Shuqair, and Muhammad Subh, and Dr. Muhammad Ghunaim. It was very interesting. Why? Because very few papers handle this issue, which are the predictors of long-term graft survival. Next, please. Here we see that we are talking about two predictors, acute rejection rate and post-transplant hypertension. Acute rejection rate, the relative risk predicting graft survival is 22.3, very high. And the second predictor is post-transplant hypertension. And here what we want to understand that hypertension also, the relative risk is 1.5 to 7. So it is a predictor of long-term graft survival. Next, please. The increased carotid intima medial thickness in children with chronic kidney disease improved after transplantation. And this is one thing good for transplantation because functioning graft will help the patient to decrease his increased carotid intima, both in carotid artery intima and femoral artery intima. Next, please. What about malignancy? Is a nightmare, malignancy after transplantation, because sometimes the patient is completely away from this risk and nobody can understand or swallow how this could happen, but it happened, unfortunately. The overall risk, according to this study from Amsterdam, it shows that the overall risk was increased by 10-fold. In male, 13-fold, in female, 8-fold. This is the overall, all cancer together. Next, please. This is a very interesting study where they look at 249 patients, and they did follow them, all of them transplanted, and they did follow them for a mean period of 13 years after transplantation, and they look how many out of them developed cancer post-transplantation. In fact, 20 out of 249 patients, which means 8%, so of 8% of patients with transplant developed cancer after a mean period of 13 years of follow-up post-transplantation. So 20 cases. Out of these 20 cases, 11 cases were skin tumor. So skin tumor is the most important cancer that can develop, followed by lymphoma, 5 cases, means 25%. And the rest are 1 case for each: leukemia, leiomyosarcoma, fibrosarcoma, etc., etc. Next, please. So the standardized risk of skin cancer, it seems that is extremely high in pediatric transplant population compared to normal population. It seems that the risk here is 222 folds in that study. In other studies, 230 folds. In other study, also 203 folds. So anytime it is in all these 3 studies, it is exceeding 200 folds the risk of skin cancer for a pediatric transplant patient compared to normal pediatric population. Now, what about the risk of non-Hodgkin lymphoma? It is increased by 46 folds in one study, 47 and 33. So at least 33 times higher the risk of developing non-Hodgkin lymphoma among those kids. So the risk is there. And especially when we talk about non-Hodgkin lymphoma, we have to remember about the EBV status. You know, Epstein-Barr virus, if we look at adult patients going for transplantation, 80% of the adult patients, they are EBV positive. So there is no risk if the recipient is EBV positive and the donor is EBV positive, there is no problem, or the problem is less. But in pediatric population, as you see here, the smaller the child, the higher the percent of negative EBV. And when the patient is negative EBV, this means that, and the donor mostly will be an adult, so we are dealing here with an donor positive and recipient negative, and here we find the problem. Next, please. What about growth and bone disease? In fact, as I said in my presentation early on, that many of our pediatric patients with end-stage kidney disease undergoing transplantation, they do have clinical manifestation of metabolic bone disease. Either they are short stature. For example, if the height is below minus 2 standard deviation, this affects up to 61.9%. You know what means below minus 2 standard deviation? Because each standard deviation is equal in adult life, equal to 6 centimeters. So the patient is shorter by more than 12 centimeters than normal population. So shorter stature. The second point is clinical symptoms of metabolic bone disease, affecting 36%, almost 1/3 of the patients. Deformities of bones, one quarter of patients. Pathological fractures, this is also a big problem, 13.4%. Aseptic bone necrosis, 13%. And disabling bone disease, 17%. Next, please. So it is a big issue, the metabolic bone disease. Now, what about the short stature? This is from North American Pediatric Renal Transplant Cooperative Study. They look at the pediatric kidney transplant height at the time of transplantation. This is not before transplant. At the time of transplantation, as you can see here in red color, we see here that the height deficit improved over time. What does this mean? It means that if you look at the left hand, the right color, the right line, you see in the late 80s, pediatric patients, when they get transplanted, usually they do have a height equal to minus 2.5 standard deviation. But if you look at the right hand in 2007, we see here that the patient, when they were transplanted, they had height deficit, maybe 1.3 standard deviation. This reflects the better quality of care during dialysis. Here we are not talking about transplantation, because part of the issue to handle this short stature of pediatric population with end-stage kidney disease is to enhance and optimize dialysis care in order to let them reach to transplantation with much possible less of height deficit. Next, please. But when we do transplant, at least if we do a successful transplant, at least we can guarantee that the child will continue to grow normally. But we cannot guarantee that the child will catch up growth, will compensate for what deficit has before transplantation, unless if the patient was transplanted, as you see here in green line. In green lines, those were transplanted before the age of 1 year. You see here that the patient, they did achieve catch-up growth. So they not only they grow normally after transplantation, but also they did achieve catch-up growth. But this catch-up growth, unfortunately, it is not observed after the age of 5 years. I mean, those who were transplanted after the age of 5 years, it's true that they will continue to grow normally, but they will continue to have their height deficit. So height deficit depend on what height deficit had at the time of transplantation. That's the reason why we have to emphasize on the quality of dialysis care in order to make it as less as possible. Next, please. Here I can compare the North American perspective with Pakistan, because I couldn't find a good study about the growth after transplantation, except in this SIOT data. It is comparable, let me say, between Karachi and the United States, a little bit less good, but the patients, as you see here, those who were transplanted after the age of 6 to 12 and from 13 to 17, they lost a little bit of their standard deviation, but they continue somehow to grow normally after transplantation. After successful transplantation, the children continue to grow normally. Next, please. This is the final adult height. Final adult height, as you see here, it is improved over time. Now, it is something around minus 0.8 standard deviation. 0.8 standard deviation, as I said before, 1 standard deviation in adulthood is equal to 6 centimeters in adulthood. So 0.8 means 5 centimeter. So let me say that a transplanted child, when become adult, he will be shorter than normal population by 5 centimeter only. So this is the average, of course. Maybe less or more, depends. But 5 centimeter is acceptable, let me say. Next, please. This is a very good study performed in Finland regarding the fractures in children after solid organ transplantation. They did study 196 children. The majority of them, 93% of them, they had pediatric kidney transplant. And there are some with liver, cardiac, kidney transplant. They did observe 166 fractures in 75 patients out of 196. So 38% of those patients develop one or more fractures. So 38%, more than 1/3. So fracture is something common, let me say. The incidence of any fracture is elevated by 6-fold, but especially very common is the vertebral fractures, because vertebral fractures is elevated by 160-fold. Can you imagine? Extremely, the patient with kidney transplantation we have to keep this information in our mind, because when it happened, the patient is having back pain, we have to consider maybe the patient is having vertebral fracture. Next, please. Now, glucocorticoid is, we all love glucocorticoid, but we all know how problematic is this drug. Not only because it suppresses longitudinal growth, not only it causes cushingoid appearance, and this is one of the risk factors for non-compliance. That's the reason why adolescents, when they come to know that due to their cortisone, they are developing this fasciitis and this acne, they stop it by themselves without telling the doctors or their family. It causes also osteopathy, and more importantly, probably more importantly, it increases the cardiovascular risk factors: arterial hypertension, hyperlipidemia, and diabetes mellitus. So this is very important. We have to keep in mind that steroid is responsible for all that, in addition to infection and change in mood and cataract. Next, please. Next, please. Next, please. Okay. So these factors, back, please. Sorry. Yeah. So these factors increase the cardiovascular risk: hypertension, hyperlipidemia, and diabetes. So the steroid is not only affecting the growth and responsible for the non-compliance, but it could be a cause of non-immunological triggers of chronic allograft failure. Next, please. Okay, now what are the treatment strategies to minimize glucocorticoid in pediatric renal transplantation? It's very simple. We have to withdraw steroid, either late withdrawal or early withdrawal, or sometimes avoid the steroid from the beginning. But the success of corticosteroid withdrawal will depend in part upon effectiveness of other immunosuppressive regimen and time since transplantation. Next, please. So as I said, there are 3 ways. Either we do it late withdrawal, early withdrawal, or avoiding. Late means that only for patients who were stable for 1 year at least after transplantation, and they are receiving now good drugs, I mean tacrolimus and MMF, and they did not develop any rejection, they do not have any immunological risk factor. Here we can try it. The early withdrawal, it is in some centers they are doing this, especially when the patient is also received induction therapy by antibody therapy, and to choose those who are low risk. Regarding steroid avoidance, it's much more complicated because it does require further validation in controlled randomized trial. Next, please. This is a controlled late steroid withdrawal in Germany between 2 groups, controlled, those who were kept on steroid and those who steroid was stopped. And see, how amazing was the result of this study. Next, please. First of all, the acute rejection rate was not higher among those who were stopped steroid. One acute rejection in withdrawal group in front of 2 cases of acute rejection in control group. So from the acute rejection point of view, there is no, at least we can say there is no at least increase in acute rejection rate. Next, please. But here we start seeing the effect. Longitudinal growth, it was substantially better in those who were where steroid was withdrawn compared to those who were kept on steroid. Next, please. So first of all, better growth. Second is less body mass index in those who were having steroid withdrawal compared to control group. Next, please. Third, hypertension. Blood pressure was less among those who stopped steroid compared to those who were still on steroid. And also less use of antihypertension medication. Next, please. Hyperlipidemia also, it was better compared in steroid withdrawal group compared to control group. And also quality of life. Quality of life in pediatric patients, end-stage renal disease by treatment modality. Here, if we compare between this treatment modality, hemodialysis, peritoneal dialysis, and transplantation. Here we look at several issues: physical well-being, psychological well-being, self-esteem, family life, friends. And if we compare between those who were on hemodialysis, peritoneal dialysis, and transplantation, we do notice very clearly that physical well-being will be better in transplant patients, and the psychological well-being, of course, it is not yet almost normal, but it is far better than those who were on dialysis. And also self-esteem is better. Family is not that much, but still is better. And friends, still those patients, they are not capable of building good relationship with friends because they consider themselves that they are still dependent on visiting doctors, doing analysis, taking drugs, etc., etc. But the thing is, of course, we have to compare how we cannot compare with normal kids. We have to compare with the condition prior to transplantation when the patient was undergoing dialysis. Next, please. Now, the quality of life in pediatric kidney transplantation and the medical non-adherence. The main issue here is the immunosuppression side effect. It has significant impact on the quality of life. And adolescents in particular are especially susceptible to non-adherence because non-adherence is the most common cause of graft failure, according to NABRETIC's 2004 report. The problem is, sometimes we do not know that the patient who is sitting in front of us is non-adherent. Sometimes we notice that the creatinine is going up, we don't know why, and sometimes we do biopsies as a child, and we see that there is some chronicity, some interstitial fibrosis, some chronic rejection going on, but we don't know why. We don't know why. So graft loss due to non-adherence is underreported because miscoded as chronic rejection. So we should not, we should always pay attention and try to see who is giving the drug to the adolescent. Is himself or herself? She is taking the drugs, or I personally prefer to let them take personally their medication, but under the surveillance of their family, because no one can know whether they are taking really or not. Next, please. What is the rate of non-compliance in pediatric transplant? It varies a lot, but it varies, as you see here, from 10 to 30%, except RISFI has reported this to be only 7%, which is good. I don't know whether I can trust or not, but I trust Rizvi because he is doing great job. But 7%, one could question why in poor people, the population is, the compliance rate is better or non-compliance is less. Probably poor people, this is philosophy, I mean now, probably poor people, they do estimate the good things better than the rich people. I don't know whether this is true or not. Anyway, in Pakistan, the less ever reported rate of non-compliance, only 7%. Next, please. What about infection after transplantation? Many infections, but we'll focus only on the most important infection, especially urinary tract infections. Next, please. Urinary tract infection is the most common post-transplant infection. It is not always simple, and it's not always simple to treat. Incidence is up to 80% by 3 years post-transplantation, and it may carry an increased risk of graft loss and death, especially in those patients who have abnormal urinary tract. That's why sometimes we have to take it very seriously. Next, please. Organism we found when we cultured the urine is not affected by immunosuppression, and urinary tract infection sometimes may mislead the doctor. It may precipitate acute rejection, and sometimes will lead the doctor to do biopsy, and sometimes we diagnose the UTI by biopsy. And treatment is dependent on the organism, but longer course is preferred. Some people prefer to increase immunosuppression during treatment of urinary tract infection. Prophylaxis is sometimes used, especially if there is associated abnormal urinary tract. Next, please. Cytomegalovirus, incidence up to 40%. It is like EBV, either primary or reactivation or superinfection. The morbidity of CMV is related to direct infection or to the immunomodulatory effect that can predispose to other infection. So primary infection, we see it when the patient, when the donor-derived disease, donor-positive, recipient negative in most, and this is the most severe infection, when the recipient is negative. Next, please. The symptom, as we all know, also most of the time, fever, myalgia, malaise, leukopenia, thrombocytopenia, and it will increase the risk for EBV infection and PTLD. And it may trigger also the development of acute rejection. The prophylaxis, as you know, by ganciclovir or valganciclovir for 3 months, 6 months, or up to 1 year, depending on the protocol. The treatment will be by IVIG and IV ganciclovir or valganciclovir. Next, please. Now, the most serious infection is EBV, because it may lead to the serious complication, which is post-transplant lymphoproliferative disease, which is somehow a cancer. The virus is latent in the reticuloendothelial cells. Unfortunately, we don't have treatment for this EBV virus. The only thing that we can do is to decrease immunosuppression, that's it. And the risk is especially high when the donor is positive and the recipient is negative. That's the reason why we see it more in pediatric population, because pediatric population, as I said, sometimes, especially in small kids, more than 50% of them, they are, their EBV status is negative. So the most serious complication of EBV is PTLD, but we don't know when and why those patients who are having infection, and here we have to differentiate between infection and disease. Infection means presence of EBV by PCR, but the patient is asymptomatic. But those patients who are having this positive PCR, they may develop PTLD. Next, please. So the incidence of PTLD has grown to 7.5%. The more intense immunosuppressive protocol, the more possibility to develop PTLD and positive EBV. Some patients, they continue to have positive PCR for EBV, but do not develop PTLD. But this continuing PCR positivity is really a new phenomenon, and its significance is really unknown. We don't know what significant is in the future. What will happen, we don't know. So PTLD is detected by biopsy of lymph adenopathy or other masses, but mostly in lymph nodes. Next, please. This is a very, very, very rare infectious complication I would like to highlight here, just to mention that it's not always simple when we do pediatric kidney transplantation. This is a case report I published maybe 3 years ago when I was in Kuwait. It was a rabies acquired through kidney transplantation in a child, a case report. In fact, this was a 5-year-old girl who was admitted to the pediatric ICU with encephalitis of unexplained cause 3.5 months after she received a kidney transplant from a deceased donor. The laboratory and imaging studies did not reveal any explanation of her rapidly declining clinical and neurological condition, which ended with death 4 days after admission. Death of another recipient from the same donor led to an investigation that revealed that the one who received the second kidney died maybe just a month before. But at that time, we did not know why the other one who died. But when we knew about the second death, we start questioning about the other recipient. We called the Saudi Center for Organ Transplantation asking for the heart and the liver, because heart and liver from the same donor went to Saudi Arabia. And we understood that the one who received the heart, he was died in the same day. So mostly it is for some technical problem. But the one who received the liver, he was in ICU with a coma and was about to die, and he died later on. So what we did, next please, the tooth cornea recipient were shown to be asymptomatic. We called them, they were living both in Kuwait, and both cornea were explanted to prevent further death. And we did call the father of the donor who is living in India, and we asked about his son who was died in Kuwait. And he said that, in fact, yes, he was in vacation in India, and he was bitten by a dog. So at that time, we removed these 2 corneas because we were suspecting rabies, and corneas were sent to a rabies laboratory of the Center for Disease Control and Prevention in Atlanta. Next, please. And rabies was confirmed and was consistent with a rabies virus variant found in dogs in the border region between Pakistan, India, and Bhutan. Next, please. To the best of our knowledge, this is the first published case report of a child who died several months after kidney transplant from a deceased donor who died of undiagnosed rabies. This is very rare, but I just wanted to talk a little bit about this case, just to keep in mind that those patients, sometimes they may develop some rare infectious diseases that we never see. That was, in fact, the first rabies I ever see in my life. Next, please. So what about recurrent disease in pediatric kidney transplantation? Mainly FSGS, congenital nephrotic syndrome, oxalosis, MPGN, particularly type 2, crescentic glomerulonephritis, Henoch-Schönlein purpura, IgA nephropathy, HOS, and SLE. Next, please. So these are the causes of allograft failure in pediatric patients. We see here, next, please, that recurrent disease is one of the causes, of course, of allograft failure. So it is important always to look at, especially in those who have diseases that may recur after transplantation. Next, please. So let's start by FSGS. Next, please. FSGS, in fact, as we know, by itself, it predisposes the patient to the risk of developing acute tubular necrosis after transplantation, whether the donor was living donor or deceased donor, significantly, I mean. So next, please. Not only acute tubular necrosis, but also graft survival. So if we look here between 4 categories of patients, living donor, no FSGS in blue line. So this is the best outcome, of course, because no FSGS and living donor. If we look at those with living donor in yellow color, living donor but with FSGS, we see here that their graft survival is far below those who had no FSGS. So the presence of FSGS by itself, it decreased significantly the graft survival. Next, please. Thus, the negative impact of FSGS appears to be greatest in adolescents with living donor transplant. Recurrence of FSGS results in loss of the expected graft survival advantage. You know, because when we do living donor transplant, we expect that because this is living donor, so we expect better graft survival. So this advantage will be lost when the patient is having FSGS. Next, please. So the conclusion is, these data suggest that until the mechanism of recurrence is better elucidated, the rationale for using living donor graft in adolescents with FSGS should be based on factors other than the better outcome typically associated with living donor transplantation. Next, please. Now, oxalosis. This is also another nightmare because very difficult to handle those patients with oxalosis because those patients require both, either in the same time liver and kidney transplantation or in 2 times. Kidney transplant alone would not cure the disorder, as you know, and oxalate accumulation would occur in new graft, sometimes catastrophically. That's the reason why we have to cure the oxalosis by doing liver transplant before doing kidney transplant. And intensive hemodialysis pre-transplant to assure lowest possible oxalate load to a new organs. Post-transplant hemodialysis indicated if there is a residual oxalate load, because we are afraid that the residual oxalate load will obstruct the new grafted kidney. And we may lose it, this new grafted kidney, and it happened. And the literature is full of papers of patients who were transplanted, but they were still having important amount of residual oxalate, and this residual oxalate will sometime develop acute graft failure. Next, please. Now, fortunately, we do have a new drug called lumasiran. This is subcutaneously administered every month, 1 dose subcutaneously. It is an investigational RNA therapeutic that inhibit oxalate production. So this drug inhibit and reduce the hepatic production of oxalate. Therefore, and it seems it is very successful and it is well tolerated. And hopefully this drug will prevent us from going for liver transplant. So hopefully with this drug, the patient with oxalosis will use it in order to reduce their hepatic production of oxalate. And when we remove all the oxalate from the body by doing hemodialysis, then the patient can do only kidney transplantation without doing liver transplantation. Lumasiran is already approved by FDA last March, just 4 months ago. And full study results will be presented at the Oxal Europe International Congress later on this year. Next, please. So recurrent disease in renal transplantation, FSGS and oxalosis can recur suddenly and catastrophically in a kidney transplant. There are, of course, several other disorders can recur pathologically with little clinical effect, like especially in IgA nephropathy, the patient can recur, but the patient may not feel anything, and also SLE, etc. Familial HUS often recurs in an established transplant and may require lifetime eculizumab. Next, please. Future strategies. So maybe we'll talk later about this. Next, please. Access to transplantation. Access to transplantation, as you know, the availability of living-related donor is highly variable. Utilization depending on cultural, religious, and economic aspects, and on availability of deceased donor graft. Child bonus in most deceased donor graft allocation program does exist in many countries. It should be existing everywhere. The child bonus, just because being a child, the child must gain certain score that make his waiting time less compared to other patients who are older in age. And we have to follow young for young approach, because these are small patients, the entire life, the entire their life are in front of them. And we have to increase trend toward preemptive transplantation and minimize the period of dialysis for those patients as far as possible. Sometimes it's not possible, but sometimes it is possible to do preemptive transplantation, whether it is from living donor or even from deceased donor graft. Next, please. This is an interesting study by Professor Rashad Barsoum, published 12 years ago in Pediatric Nephrology, about access to kidney transplantation. Professor Barsoum, he mentioned here about the development of living donor transplantation in Egypt and how the commercial organ donation major allograft source for children in developing world. You see here that the rate of unrelated donor exceeds by levels the related donors. So everybody hoped that if we want to solve the problem of pediatric patients by doing more transplant, we do hope that should not be at the expense of commercial organ donation. Therefore, the global ban of commercial donation, according to Istanbul Declaration, at least must lead to increased utilization of living related donors and the urgent need for pediatric cadaveric organ harvesting programs. Next, please. So to conclude, moderators, Professor Hussein and Professor Fatina, marked improvement of graft survival rates in children and adolescents during past 25 years. This is very clear. Mortality still increased 30-fold in young adults with childhood onset ESRD. Most relevant risk factors are extended dialysis time and choice of immunosuppression. The future strategy should depend on, first of all, shorten or avoid dialysis period by early transplant or preemptive transplantation, to focus not only on rejection rate and transplant survival, but also on comorbidity, particularly cardiovascular and quality of life. And we have to limit infection and malignancy risk by tailored immunosuppression, and to push global development of deceased donor transplant program. Thank you very much.
Thank you very much, Professor Bassam Saeed, for this very nice, illustrative, very comprehensive aspects and issues of pediatric transplantation. I prefer to leave the mic to Professor Fatina, and I leave my comments at the end of the discussion. Dr. Fatina. Please unmute yourself, Dr. Fatina. Unmute yourself, Dr. Fatina. Okay, Dr. Fatina. Yeah. Yes, it's fine.
Thank you very much, Professor Bassam, for this very illustrative talk about pediatric renal transplantation. Actually, you covered all the aspects regarding this issue. Very good talk, collecting all the data about renal transplantation in children, the complication and the challenges we are meeting in renal transplantation in children. So thank you very much, Professor Bassam. And I think, do you have any comments or questions, Professor?
Okay.
Discussion, yes?
Okay, yes. Let us start with Professor Faissal Shaheen. He is here in the camera, then Professor Riyad Saeed. Okay, Professor Faissal.
Okay, thank you. Thank you, Bassam. It's elegant talk as usual. I had just a few points which probably we discussed it before, that some of your statistics is a little bit old, so 2016. and that number of transplant probably doubled now more than what you have. I know that we have overall transplantation in the Arab world around 3.4% from the total number worldwide, which is very low if we compare it, especially in children, as you said. We have a strategy in Saudi Arabia to give priority for the children. That's why our number is a little bit higher than the other in the Arab world. So we are giving, age for age, and at the same time we give more point to the children if they are in the waiting list, and we prefer to have probably, as you mentioned, preemptive transplantation for the children. That's why our number is good. We published one article long time back from GKC, Jeddah Kidney Centers, around outcome of pediatric transplantation in one single study. Probably at that time, Al-Qusi also was working with me at that time, and it was probably 3 years survival was 100% graft survival and patient survival, which is showed that it is very good outcome. As I mentioned, I have a few points, if you allow me, Mr. Chairman.
Yes, yes, please.
Please.
About the, one of the slides you show that during infections, you increase the immunosuppression drug, which I don't know, this is not my practice or our practice here. During infections, we decrease the immunosuppression drug in order to overcome the infection. Probably this is different from one place to another. Another thing about congenital anomalies of the children, which we have it, like atonic bladder, like what you do with such cases in transplantation and what is the outcome? Because this is of the major issue in pediatrics, that we have anomalies and probably malformation of the congenital of the urinary tract, and that's why we face a problem post-transplantation. And this one of the issue, which probably it's not addressed. You addressed many things anyhow, excellent, but probably this you didn't mention a lot about it. About the case of rabies, that I was involved in that case, and also the European country, Eurobia was involved with Dimitri, with BRs about investigating this case of rabies as a rare case. It is even WHO aware of that rare case of transmission of rabies with transplantation, and it was a unique case. And as you mentioned, you discovered it in Kuwait, and we follow up, and also we have a proof that it was rabies transmitted to some of our patients. But again, it's elegant talk, and thank you very much, and I appreciate. Thanks.
Thank you very much, Professor Faissal, for these points. I think the question is regarding the presence of abnormal lower urinary tract, contracted bladder. What's your experience? Yes. And I presented in the introduction some of the very nice papers published by Professor Fatina and her group. Dr. Bassam.
Yes. First of all, let me answer his first question. Thank you very much, Professor Faissal Shaheen, regarding the what to do with immunosuppressive medication when the patient developing UTI. In fact, what I said is some people, depend on the experience and practice of everyone. Because the presence of infection by itself, it may trigger the rejection. And that was the rationale why some people, they do increase the immunosuppression dose. We understand that the curing the infection require no immunosuppression at all. But of course, immunosuppression cannot be stopped. Maybe increasing the immunosuppression may delay the recovery, but from one hand, but from the other hand, it may protect also from developing acute rejection. This is what I can say about this point. Regarding your second question, yes, please.
But excuse me, Professor Bassam, regarding this point, if I have clear infection Pyelonephritis, I know that UTI, the rare risk for rejection. But it is not convincing at all to strengthen immune suppressive in case of active infection. But according to the immunological risk and according to the type of infection, if it is just cystitis, it is completely different from pyelonephritis. So according to the state of infection and the immunological risk of the patient, I can deal with the patient. Sometimes we give umbrella of antibiotics and keeping immune suppression. But for us, the majority of nephrologists reduce immune suppression in case of severe infection.
Yeah, I do agree with you. I personally, I do not increase. But
Yes.
I did mention it because I read several reports about this. But you know, to make a difference between cystitis and pyelonephritis, most of the time we are dealing with pyelonephritis, but in patient who is immunocompromised, it's not always easy to make the difference or to differentiate the local, whether it is high UTI or low UTI. Anyway, of course, there is a risk of not to cure the infection when we increase immunosuppression.
And now, sometimes if we give antibiotics, the antimicrobial may interfere pharmacokinetically and pharmacodynamically with immune suppressive drugs. So yes, sometimes it worsens the situation. So this is why it is wise to assess risk benefit. And if the patient is not in severe immunological risk, it's better not to increase and to cut down some immune suppressive drugs in this situation.
Yes, yes, I do agree with you. Now, regarding the abnormal urinary tract, of course, many of those kids, they do have abnormal urinary tract, and we have to address this issue in cooperation with our urologist, pediatric urologist, and to see what can be done at this stage before going for transplantation. Of course, there is a big category, we call it acute, which means congenital kidney and urinary tract anomaly. So we have long list of congenital anomaly of kidney and urinary tract, but some of them, they are not creating problems later on, like hydronephrosis, for example, if it is idiopathic hydronephrosis, and if there is simple VUR, but some patients, they do have a neurogenic bladder. I think those patients with a neurogenic bladder, they are prone to develop also later on after transplantation, the obstructive uropathy can also develop on the graft itself. That's the reason why we have to fix the problem before going to transplantation. This is the decision depend on the surgeon, not on us. The surgeon in these cases, usually they do bladder augmentation, and the patient, after that, they will do self-catheterization. Self-catheterization can be either from the umbilicus or from the normal way, in order to keep the bladder being empty on a regular basis every 3 or 4 hours, etc., etc. This is a huge task for the parent, but usually the parent, with time, they will get used to it and they will do it, and usually they are good compliant to this. Otherwise, we cannot go for transplantation before fixing the especially when the bladder, the intravesical pressure is high, because when the patient is having high intravesical pressure, this will affect the graft itself, and the patient may lose the graft as he lost or she lost her native kidney.
We have a small experience here at Urology and Nephrology Center that was published 17 years ago about this issue, and we found, as Professor Bassam mentioned, if we correct lower urinary tract abnormalities before transplantation, the outcome is good, rather than to delay the management. And as you mentioned, Professor Bassam, it depends upon the collaboration with the surgeon, urologist, and pediatric urologist, with neurologists, and with us as nephrologists. So this is, and we have urodynamic studies, and we evaluate everything. And if corrective surgery should be done before transplantation. Otherwise, it will adversely affect the outcome of transplantation. Dr. Fatina, do you like to add here a point from your study?
Yes, actually, yeah, in our series with children like those with neurogenic bladder, with problems in the bladder, actually usually the decision is that of the urologist, the surgeon. And in our series, most of the patients were operated before transplantation, and they were kept on CIC after transplantation. So I think this is the best way to manage such cases.
But our experience with CIC, although we don't have current data because we observe and manage the patients day by day. Yes, urologists have their intervention, but we admit the patient frequently because of UTI, and it is very dilemma and problematic issue. I don't like CIC, but it's mandatory if it wasn't if it is not done.
It's mandatory.
So we educate patients, we educate parents, and because we don't deal with very young child, we deal with almostly adolescent. We depend upon the intelligence of the child and educating the child.
And sometimes they depend on overnight catheterization.
Yeah, it is miserable situation. But if the patient is living with CIC and then admitted to the hospital with fever, we put catheter for drainage to alleviate him and to drain the bladder properly at the time of admission until antibiotic work. Okay, Professor Bassam?
Yes.
Okay, very good.
Okay, Professor Riyad, thank you very much, Professor Faissal, for your points. I know that you have many points, but I think the idea of Professor Bassam today is to give panoramic view about pediatric issues of renal transplantation. And even if the data registry is a little bit old, but I think it is working. The concepts are valid. And I agree with all the points mentioned by Professor Bassam. And I'm happy by mentioning Lumizaran because I read it, and I read the phase 1 and phase 2 study and the FDA approval because it is one of RNA interfering therapeutics. It is a magic bullet because we have a gloomy experience here with a few cases of primary oxalosis. Because we don't do liver transplant for a couple of cases. We just apply protocol to reduce oxalate. And then the lesson was very gloomy, recurrence 100%. This is why we stopped the protocol of reducing oxalate by pharmacological management. And we leave this issue for combined liver and kidney. So it is miserable situation, oxalosis. We don't like oxalosis. And we don't have all facilities, and sometimes it is problematic to say it is primary oxalosis or not. So it is a very difficult issue. Professor Riyad, please unmute yourself, Dr. Riyad. Dr. Riyad, unmute yourself.
أيوة.
Yes.
مساء الخير.
We hear you.
Dr. Okay. Dr. Bassam, I think it was an elegant talk. I have a couple of comments. Really, you are really completely thorough. I'd like to pick from the last comment of Dr. Hussein about oxalosis. And I agree 100% with Dr. Zamina Bassam about liver first and then kidney. I don't do really simultaneous kidney liver transplantation at the same time. In fact, next week we have a patient who's 14-year-old is coming really for both liver and kidney transplant for primary oxalosis. So we have around 3-4 patients we transplanted with this situation. Concerning the study that Dr. Bassam mentioned about Jordan, and we have a good number of pediatric patients being around 8.8 pediatric patients per million per year. Yes, I think that's true. In fact, maybe even more than that. And this reflects what really we have transplanting mostly we have in the private sector and in the Royal Medical Service sector. In the Royal Medical Service sector, most of them Jordanians. I'll say 80% Jordanian nationals. And in the private sectors, it's the opposite. We have almost around 70 to 80% non-Jordanians, and they come to us really from Palestine, from Yemen, from Iraq, and Libya. So we have this number. In fact, in my practice, for the last 22 years at Jordan Hospital, I'll say among 1,000 kidney transplant, I have at least, I'll say 20% of them are pediatric patients by definition in our hospital, 14 years of age and less. So we have a good number of pediatric patients being transplanted. The youngest patient that we transplanted 6 months back is 3 years old, and that was with the help of our pediatric nephrologist, Dr. Sheashaa, and the result really was really good. Concerning steroid withdrawal, and here I don't know what's the policy. Personally, I don't draw with steroids. I'll keep the patient on a minimal dose, even 2.5 milligram of cortisone on daily basis. I'm always worried about rejection that can occur. I don't know what's the statistics with Dr. Bassam concerning this issue. Finally, obstructive uropathy that we are just chatting about now. It's a hard time again. I will not leave it for the surgeon to decide what he's going to do. Ultimately, this is our patient. Ultimately, as you mentioned, we are the one who's going to face day-to-day activities and day-to-day infectious complications. I have a couple of patients with ileal loop conduits. They're being performed to start with, and then transplanted. That self-intermittent catheterization with young boys, with adolescent, I think it's, as you mentioned, it's worrisome. And usually the patient, what they do in order not to catheterize themselves, they don't drink water. I have one child, used to be 7 years old. She stopped drinking water during daytime and nighttime most of the times in order to avoid self-catheterization. Here you remember now acute rejection, infection, and all the potential complications. Overall, Bassam, I really enjoyed your talk. Thank you.
Thank you very much, Professor Riyad. These very valuable comments, Dr. Bassam. Then Professor Fatina about, because I expected that Professor Fatina has experience in liver and kidney. So Professor Bassam first, please.
Yes. First of all, regarding the point of the first question is oxalosis. Oxalosis, yeah, it's a big challenge. I mean, when we see a child with oxalosis, I pray God that this patient will remain in life, because there is a long way to run in front of him, not only because liver transplantation is not easy to do it, but also because transplantation, kidney transplantation will not solve the issue for him, except if it was preceded by liver transplantation. That's why this new drug is really a magic drug, especially for those kids. Because when we see that lady who donated half of her liver and one of her kidney to one child, I mean, this is fantastic. But this is not always that we can see this huge donation from the mother to her child. Anyway, oxalosis remain a big challenge for all of us, nephrologist, surgeon, and liver transplant surgeon, and the patient and the family. And it's not always also easy to confirm the diagnosis of oxalosis type 1 or type 2, because it does require to do genetic testing and look at the type, because essentially idiopathic hyperoxaluria, there is type 1, type 2, type 3, but usually type 1 is the only one that can develop end-stage kidney disease. What was the second point of Professor Riyad Saeed regarding, let me remember?
Steroid
withdrawal, or yeah. I understand. Look, in my experience, in the whole Middle East, there is no steroid minimization. But if we go to the West, it does exist, of course. It does exist, and I have shown studies that showed that those who were stopped steroid, they do not have increased rate of acute rejection. I fully understand that this fear is there. We always fear of increasing acute rejection rate. But in fact, if we choose our patient properly, I mean those who are low risk and those who did not develop any complication for a year after transplantation, I think it can be tried. It can be tried. And there are lots of benefit out of it. You see that the growth will be better, the blood pressure will be lower, the body mass index will be less, the lipids will be less, etc., etc. There are so innumerable benefit we can. But I understand that many people are not afraid, but are hesitant to do it. It does require center of excellence, I mean, with very close observation, and we have to be very selective. And this is a key point. We have to be very selective which patient may deserve to be decreased steroid dose.
We have here, we have at Urology and Referral Center good experience. And I know Professor Fatina will say this policy doesn't work at Cairo with Professor Fatina, but our protocol either for adults or
we have
according to the immunological risk. If immunological risk is not high, we give routine basiliximab induction and maintaining the patients on tacrolimus, mycophenolate, mofetil, and steroid only for 7 days until tacrolimus level is okay. We stop steroid. That's our protocol, and it is specific. Yes, I know in pediatric there is increased risk of immunological response, but if we discuss growth is very crucial. Growth like kidney is important. So the only way, the only strategy to improve growth for the first year after transplantation is cut down of corticosteroid. Because I think growth hormone, there is some protocols or some reports or recommendation from pediatrics, it either is not beloved or to be avoided or contraindicated in the first year of post-transplantation. So if according to the immunological risk, the child is not high immunological risk and we use induction therapy, it's better to stop steroid. And it is successful in our experience in adult and pediatric. And we published our experience in randomized controlled trials, and it confirms what Professor Bassam mentioned, significant reduction of post-transplant hypertension, post-transplant diabetes, metabolic abnormalities, with no bad impact on rejection, graft, or patient survival. So, but Professor Fatina has an excellent service, and she will speak about her experience regarding steroid, stopping early steroid withdrawal. Dr. Fatina.
Yes, actually we had this trial about 4 years ago. However, as regard our experience, we failed to apply this early steroid withdrawal. Most of the patients who were put on early steroid withdrawal, they went into acute rejection episodes, and we unfortunately was forced to start steroids, and this was proven by biopsy. So we stopped this trial, and it was done for almost 30 patients. Most of them went into acute rejection. I don't know, though they were low risk, they were on. So, Professor Riyad, I agree with you. For our patients, we are now using steroids. We minimize the steroids by time, and we put on the lowest steroid dose. As you had mentioned, maybe 0.25 or so, and we reach 2.5 milligram every other day, but we keep our patients on this low dose of steroid. Actually, I discussed this issue with Professor Hussein before, and they succeeded in their center to reach this steroid-free protocols, but
it doesn't
unfortunately
work. Yes,
we didn't.
Yes.
Well, I think because
it didn't work with us.
Riyad,
Yeah.
we have prerequisites. We have
I think
prerequisites. So
We applied all this.
yes, sometimes we think of steroid withdrawal, rapid steroid withdrawal, but there is tacrolimus level was not fine. So if after 2 weeks, if the steroid is continued beyond the 2 weeks, we don't stop steroid. We give a small dose. So
if you allow me,
according to
please.
yes, yes,
You know,
please.
you use induction. Basically, we don't use induction here in our place. That may be
Yes.
the difference. Use
Yes.
Lab for your induction. Basically, we don't really use induction for straightforward cases. And that may be why really we are shying off of reducing the dose of the steroid or cutting it. But in your area and in your practice with the induction that you have, and I think you have a good safety margin for taking the steroids out.
So without induction, there is no steroid withdrawal. Secondly,
we use induction,
without TAC and the mycophenolic acid producer, either mycophenolate sodium or mycophenolate mofetil, no steroid withdrawal. To the extent, even for adults, if we have pregnant lady who was treated with steroid withdrawal and then now she is pregnant, so we resume steroid, small dose steroid, because we stop MMF. Or yes. So we have prerequisites and we apply, and it worked well with us. And I remember the Wisconsin experience, 15-year follow-up of steroid withdrawal, confirming no difference in rejection, no difference in survival, graft or patient, but good outcome regarding metabolic obesity and other side effects, even in adults. So if we are if we have a good experience and we can do it.
We are going to try once more, Professor.
Yes, but Professor Riyad agree with us.
He deserves to do this
because he has no induction.
Yes.
Okay.
May I comment about this, please?
Yes, please.
Yes.
Yes. Regarding the induction therapy, in fact, it is a must when we deal with early steroid withdrawal. Steroid withdrawal. But when late withdrawal, which means at least after 1 year, here it is not necessary that the patient had induction therapy. If we do late steroid withdrawal, which means the first year patient will be kept on steroid, and the patient will be from the beginning low risk, and the patient did not develop any problem, especially acute rejection, especially when we do protocol biopsy. So the patient will be biopsied even if the patient did not have any problem that may push us to do biopsy. Those patients, when they reach 1 year post-transplantation, if they fulfill all these criteria, we may consider here to withdraw steroid, even if induction therapy was not part of their protocol. So induction therapy is only when we consider early steroid withdrawal.
I mentioned my statement about induction is mandatory because we are afraid of late withdrawal to the extent after 2 weeks we will continue on a small dose of steroid forever unless there is compelling indication to stop steroid. So we don't apply, or in our center here, we don't apply the strategy of late withdrawal of steroid. I think Professor Fatina, regarding the issue of liver and kidney transplant, I'd like to hear from you about your experience. I know that you have few cases, but it is good to hear from you.
We have few cases. We have, yes, we have till now about 8 cases. The last one was transplanted about 1 year ago, and all our patients were transplanted simultaneously, liver and kidney transplantation simultaneous. However, the last patient had heavy oxalate load after transplantation, and unfortunately he started dialysis 1 year after transplantation, although he was transplanted combined liver and kidney transplant. I would recommend, as Professor Riyad had just mentioned, to do first liver transplantation and then to go to kidney transplantation transplantation after getting rid of most of the oxalate load. And on the intensified dialysis before transplantation. Most of our patients were kept on intensified hemodialysis, 5 or 6 sessions per week, online hemodifiltration, and we thought that would be enough to remove part of the oxalate load, and we went to simultaneous liver kidney transplantation. It worked for most of our patients. 7 out of the 8 were doing very good and fine. However, the last patient unfortunately suffered from severe hyperoxalate load, and here again he went again to dialysis, and probably we might now go to renal transplantation after some time. But he has a very good liver graft function and failed renal or lost graft for the kidney.
Very
this is our
nice.
experience regarding. Yeah.
Dr. Bassam, unmute yourself. Do you have a good case, a number of cases in liver and kidney transplant? What's your experience?
No, we don't have lots of cases. We do have 2 cases actually. One patient died, and the other one is doing very nice now. But unfortunately, as I said, after the liver transplantation, he did develop some severe complication. He was out of all this now, and then he did kidney transplantation 3 months after the liver, and now he's doing very fine.
Regarding the use of tacrolimus in pediatric in these young patients, do you have any problems in the dosing of tacrolimus or the level? Do you measure the cytochrome genetic, or I would like to hear from you about these points. Unmute yourself, Avash.
Sorry.
Yes.
Yes. Unfortunately, this is very important to do, but we don't have it, the cytochrome, because now, you know, the pharmacogenomics now is the matter of today. Now for most of the immunosuppression we use, especially with regard to calcineurin inhibitor and especially with tacrolimus, because we do notice that when we monitor drug level, it's okay for 85%, 80 to 85% of the population. But for the remaining 15 to 20% of the patient, we don't understand what's going on. Sometimes we give high dose, but the trough level is very low. And the opposite scenario is also sometimes true for some other patients. I mean, we give a little dose, but the trough level is extremely high. This, of course, depends on the metabolism capacity of each and single patient and every patient. How to estimate this, we have to look at the cytochrome capacity of each patient. And unfortunately, this is not available to us. That's the reason why for those patients, it's better to calculate the area under the curve and not to rely on the one single drug level. But this is costly because we have to do at least 4-point monitoring in order to calculate the area under the AUC for tacrolimus. Otherwise, the patient may be exposed either to overexposure or underexposure. Overexposure, as you know, will lead to drug toxicity and nephrotoxicity and also increased creatinine. And the opposite is also when the patient is underexposed, this may lead to acute rejection. And I have to mention here one point regarding the Druze community in Syria. This problem, we have noticed that, especially because you know, the toxicity is a donor issue, it's not the patient issue. When the donor is coming from this community, because we know already that those community, they are metabolizing tacrolimus very slowly. That's the reason why when you give them tacrolimus, they will get into toxicity very quickly, unless if you did pay attention to this and you give them small doses, and you see that if you give them from the beginning 1 milligram morning and 1 milligram in the evening, and you will see the trough level is something around 7 to 8 despite the small dose. So this is genetic, and we have no way, as you mentioned, to monitor the cytochrome in those patients. We are trying to help our patients with what is available to our hands, but we hope that one day it will be available and easy accessible to do this pharmacogenomics to all patients before going to transplantation. We can classify our patients early on before going to transplantation in order to know and classify our patient whether the patient belongs to low metabolizer or rapid metabolizer or standard metabolizer. This is very an important issue you raised. Thank you very much, Professor Hussein.
We don't have here as well pharmacogenetics or pharmacogenomics, but we have naive study that was conducted at our, I think, 70 patients post-transplant in collaboration with Greece people, and it is accepted a few days ago in one of the very prestigious journals in pharmacology with impact factor 4.4, so it is very nice. And I think the majority of our patients were belonging to the non-fast metabolizer or the slow metabolizer or heterozygous and not homozygous rapid metabolizers. So it will be at hand soon. And I think in children specifically, I think it is important, because if we know that the child is a rapid and fast metabolizer, it's better to give this child a bigger dose, and this will lead me to ask you the second question, because we have dogma here not to give tacrolimus 3 times. In the old cyclosporin, we give for the children cyclosporin every 8 hours based on small intestine and absorption. But in tacrolimus, we say no evidence. A few days ago, I read an article in press about 3 times tacrolimus dosage that help a lot in reducing the dose of tacrolimus. I want to know from you, do you have an experience to give tacrolimus 3 times instead of 2?
No, I have no experience. Yes, sorry.
Yes, go ahead, please.
Yes. I have no experience with using tacrolimus thrice a day because it is rarely required. I did read articles about this because it is especially beneficial for those patients who are metabolizing quickly their tacrolimus. So if they metabolize quickly, even if you increase the dose, this will create some hours, especially at the end before the next dose, where they will be underexposed. So the variability in drug exposure between the few hours after giving the dose and the few hours before the next dose, this variability will expose those patients to develop donor-specific antibody. So this is one risk. That we have to avoid by either giving the drug 3 times a day, or the better alternative here is to give the Advagrab, the long-acting. The long-acting is going to solve this problem because the drug will be released very slowly over 24 hours. So I guess that the problem for those who are rapid metabolizer of tacrolimus, the solution here is to give them the long modified release or the Advagrab.
You are not convinced by the thrice daily dosages of tacrolimus?
There is no data to confirm how effective is to prevent the problem and when to do it. But I think from the theoretical point of view, this is my own analysis. As long as we do have some prolonged release,
and I think there is a trend. sorry for interruption. I think there is a trend to use even inversus. Inversus is a prolonged release with improved pharmacokinetics, and it is not present in our country. It's present in Spain and Italy and some countries, and it is improved pharmacokinetics to the extent that tacrolimus is absorbed from the lower part of the intestine with a smoother curve, more smooth than even alvagraph. So it may be a solution. Yes. Yes.
Yes. Yes. Yes.
Let us look at the chat because there are some points here. I know that it is very long presentation and you are tired now. So it's 5 minutes,
No
and
problem.
5 minutes and we'll stop discussion.
No problem.
There is comments from Professor Riyad or Professor Faissal Shaheen. What is your experience regarding crossover transplantation in pediatrics? I don't know. I don't understand the crossover transplantation. What's meant by crossover transplantation in pediatrics? I don't know. What's your opinion about using CNI in pediatric 3 times a day? We discussed it already. And it is still cyclosporin, okay. Cyclosporin in short gut, we have good experience in children in the era of cyclosporin and short gut in children or children under anticonvulsant therapy, because anticonvulsant will enhance the metabolism. For these children, we use cyclosporin many times, 3 times per day. But for tacrolimus, we don't use it 3 times in a day. But as I mentioned, yes.
Dr. Hussein, we had a patient who had difficulties with tacrolimus. He couldn't achieve a drug level, although he was on a very big dose. So actually, we shifted him onto 3 times per day dose. And after this shift, he started to get higher levels. So this, I don't have experience about this, but this is the only patient who we tried with him to put him on divided doses 3 times per day, and actually he improved after this.
And if my memory is working well, the study that was published a few days in the journal for the 3 times, and this is the first paper I read about 3 times per day for tacrolimus. The conclusion was it is as effective as twice, but with a smaller dose to reach the level, as our professor mentioned. So it is. I wonder why explanting corneas, which are bloodless, and they don't need immune suppressive medication. This is a question, Professor Bassam, for the case of rabies. No, and regarding the case of rabies, it is very stimulative that I asked Professor Ahmed Halawa, because he wrote a chapter about infection transmitted by the donor. And I think within a couple of months, he will give, after the chapter will be released, he will give a talk about infections in general transmitted by donor. So regarding this case, why explanting corneas? This is a question.
Yes. In fact, both corneas were explanted to prevent further death, because we consult ophthalmologist, of course. We did not do the explantation of cornea just by ourselves. Anyway, the ophthalmic surgeon is the one who removed the cornea. When we consult them and we told them that there is a risk that this cornea may be, in fact, infected with rabies virus, they said that the patient may die from it. That's why better to remove it now to prevent further death. And this is what was confirmed later on, because these corneas were sent to the rabies laboratory, and rabies was confirmed and was consistent with rabies virus from the same region from where the donor came. So it was a preventive measure in order to not the patient die, of course.
There is a question about variability of tacrolimus. Does exist in the same patient? Yes, there is intra-patient and inter-patient variability, and I think it will be discussed in future presentation. I think, because the time is now very delayed. So, Dr. Faissal, do you have any points you want to add?
Just quickly, I rather prefer to give any kid 3 times tacrolimus, not 2 times at all. I know that probably you have such experience, but I get used to this and I trained for this. That
For how many patients?
well, I have at least 20 patients.
Very nice. It is publishable, Dr. Faissal.
Yeah, I have it and I get used to it. This is my trend in on those patients because I will not. I prefer this not to increase the dose, and he has toxicity. But if the level is low, he may get rejection. So the best way is to give 3 times, and I am giving to all the kids 3 times, not 2 times at all. And the other alternative is to give Advagraph, which is a good salt, but I don't use Advagraph in the de novo till now. I am using it later on. So probably after
it's
that.
Better, yes. It's better to postpone it after the steady state. Although the industrial company push toward the use of these drugs, but I think it is not good to start with this drug in the early days after transplantation. But regarding the inversions that I mentioned, it seems that its pharmacokinetics is better because in Advagraph we increase we don't translate 1-to-1 the dosages, but Advagraph 1.2 for all change from immediate release to Advagraph. In inversus, it may be 0.8 because its bioavailability is better than the immediate release. Yeah. So this is a new technology, and we hope that we have all these facilities. Dr. Riyad,
مساء الخير. أولاً concerning really this variability of the drug levels and using larger dosages or 3 times, basically what we are using convert our patients from rapid acetylizer into a slow acetylizer, okay, by giving them kinazole or really calcium channel blocking agents like diltiazem. And we have a good result by achieving a decent level with constant level that we have, very little variability over the course of years. We keep them really on a small dose of diltiazem, either it's long-acting or slow-acting, but I did not really use 3 times weekly. Concerning Advagraph, my experience with it really mainly for primary induction treatment, not really just switching. It's de novo therapy. And we have beautiful results really for that. Just we start the dosage basically a couple of days before, most of our patients are living related on the regular Prograph, tacrolimus, regular medication. Usually we start the day before transplantation. And with Advagraph, we use 2 days early because really you look about the early part of 24 hours, you may have little bit area under the curve is low. So we try to avoid this by giving the drug 2 days earlier before transplant. This is scheduled transplantation. And we have a good result. We have no trouble really with using this drug in this fashion. But switching it, I did not really use it so far for switching from short-acting, which is regular tacrolimus, to Advagraph. I don't know about your comment.
I think it is rational to give it 2 days before transplantation if we use it de novo. And we will depend on the level. Yes. So this is your experience, and it is. I think it is good, but we are afraid because sometimes there is dogmas in the brain. So the problem in our brain, not in the pharmacology. Whatever you succeed to have level, it's okay. It's fine. I have no objection about your strategy, so long as you follow the protocol and the drug level is satisfactory. The problem is in Advagraph, we need larger dose to achieve the same level. So it is a little bit costly than the immediate release tacrolimus. Anyhow, I think its use is increasing, either Advagraph or Inversus over the world.
Yes.
Yes. Regarding the Epstein-Barr virus negativity, another point, in pediatric we expect negative Epstein-Barr virus, as you clearly and elegantly mentioned, Professor Bassam. And this in the Western community, this is why belatacept is not be referred in pediatrics, because the majority of pediatric patients will be negative, and Platacept is not a good drug. And one of the prerequisites and the exclusion criteria is Epstein-Barr negative, not positive. So this is another point toward the value of Epstein-Barr virus positivity. Do you like to add anything, Dr. Fatina?
At this point? No.
Not this point. No, not Epstein-Barr. In general, yes. To conclude the session, yes.
No, thank you. Yeah. It was very nice talk by Professor Bassam and very nice discussion with our dear professors, Faissal, Shaheen, and Professor Riyad, and enjoyed it very much. Thank you, Professor Hussein.
Thank you very much, Professor Fatina. Really, it is fantastic presentation, and it clarified, and as I mentioned, this panoramic presentation of all issues of pediatric transplantation. And I hope that in next sessions, we will focus on some aspects of pediatric transplantation, because transplanting a child is very difficult task. Needs the collaboration between and the seriousness and the care, because it is not an easy job in the early days of transplantation and later on with the children. I have nothing except thank you very much, Professor Bassam Saeed. Really fantastic presentation, and it will be a very nice addition to our library, and will be uploaded inshallah tomorrow morning to the YouTube, and I'm going to send the link to all colleagues, appreciating your efforts, Professor Bassam, and this exhaustion and discussion. Thank you very much, and hoping to meet you again and again and again. Now the mic is to you to close the session. Dr. Bassam.
Thank you very much. Thanks again. I am the one who must thank you and everyone in this session, because you gave me the opportunity and the chance to speak in front of all these scientists from Egypt and from the Arab world. This is a great opportunity for me. It's a great honor for me to speak. And I hope that this session was beneficial for all of us. And sharing experience is very important and very, very needed, especially in this tough time. And hope that we'll meet again and again. And will always be a great pleasure to see you and your great efforts. And thank you very much from the deep of my heart.
Thank you very much. And the last welcoming message from Professor Saeed Khamis. Prof. Saeed.
Thank you, Professor Hussein, and thank you for my professors, Professor Bassam, Professor Riyad, Professor Fatina, Professor Faissal, and all colleagues. Actually, it was amazing presentation from our Professor Dr. Bassam, and I hope it will be repeated again, inshallah, soon. Again and again, welcome, and thank you for all. Thank you for you, especially Dr. Hussein. Thank you so much.
Thank you very much, and hoping to see you, inshallah, قريبا, Dr. Bassam. شكرا جزيلا. شكرا دكتور فيصل، دكتور فاتينا، دكتور رياض بيه. نلقاكم على خير، والسلام عليكم ورحمه الله وبركاته.
جزاكم الله خير.
السلام.
السلام ورحمة الله وبركاته.